alone. But the fact is that to use the terminology of war, it's very much it's not something that we can win when you try to fight a healthcare problem utilizing military terminology. And so again, it's not something that we are winning, and really we need to kind of refashion what we mean by that. Another myth is that addiction is completely a choice. Again, there are choices that people make, whether it's choosing to get into treatment if treatment is available. So there is an element of choice. I do not believe that people are automatons, but it is not completely a choice. If we say it's completely a choice, we're going to be adopting a moralistic view of this, and that's not necessarily the most helpful way to see it. Likewise, addiction is totally due to genetics. That's not been shown to be true either. Now, we do know that genetic predisposition exists in some individuals with SUD, but we also know there's a lot more going on there than just our genetic profile. Another myth that a lot of times our clients can fall into is that a person can love somebody enough to change them. And I think that's where we have to look at that element of a person making decisions for themselves. And it's very difficult when you love somebody who struggles with SUD or who lives with SUD. The flip side of this is that sometimes people feel that giving any help to a person with SUD is somehow enabling, and that's certainly not the case. You can help somebody without enabling them. Last two stereotypes or myths is that most people with SUD are homeless or unemployed. The vast majority of people with SUD are housed and are working. And then finally, a person will only stop using drugs when they hit bottom. That was a belief for many, many decades in the substance use treatment field. And it comes from a lot of research that was done in the 1940s and the 1950s, where it believed that there was kind of a single trajectory for people with substance use disorder, specifically alcohol use disorder. And what we now know is that every person, not to be punny or anything, but every person has a different bottom. And so, it doesn't mean that a person has to completely lose everything and come within an inch of death before they stop using. So we need to be mindful of these myths and stereotypes and how they can perpetuate some of the things that we see with some of our clients. So let's look at how do we define addiction. This is important. So addiction is a treatable disease. Okay, chronic medical disease involving complex interactions involving brain circuits, genetics, the environment, and individuals' life experiences. People with addiction use substances or engage in behaviors that become compulsive and also continue despite harmful consequences. I'm actually going to turn it over really quick to my teammate, Adam, if I can do that. If you can cover the next slides, because I'm getting called away. I've got kids here. Adam, can you pick up on the next slide? And Kashawn, I'm going to give this control to you. Is that okay? Okay, I'm going to give you, hang on a second. Eli, you're on camera, buddy. Okay, hang on. Kashawn, I think I got you here. Hang on. Kashawn, can you still hear me?
I can hear you.
Okay, I'm going to try to stop sharing here. And there we go. Hang on. You got it, Kashawn?
Yep.
Yeah, you got it. I think the next slide's where Adam's going to pick up. Yeah. Got it,
right.
Got it, Adam? Adam, you got it? Okay, Kashawn, if you can do this. Yeah, I got you now.
You got me? All right. So as Paul mentioned, just another definition of recovery, lived experience of improved life quality and sense of empowerment, that the principles of hope, choice, freedom, and aspiration that are experienced rather than diagnosis and occur in real-life setting rather than in refined atmosphere of clinical settings. Recovery is a process rather than an end state, with the goal of being in an ongoing quest for better life. Next slide. So why start an OBOT? Next slide. As Paul was mentioning, the mortality and morbidity, some current stats within the last few years, as you all can see. In 2018, an estimated 10.3 million people in the U.S. misused opiates, with 2 million meeting the criteria for an opiate use disorder. In 2017, 47,600 people died of an overdose that involved opiates. That includes fentanyl, and fentanyl analogs accounted for 28,400 of these deaths. Drug overdose deaths involving heroin rose from 1,960 in 1990 to 15,482 in 2017. Drug overdose deaths from prescription opioids rose from 3,442 in 1990 to 17,029 in 2017. Next slide. Again, talking about, well, Paul was talking about recovery language. Stigma is another huge component of this, another huge component of fighting and being an ally for those in recovery. The word stigma is used pretty interchangeably nowadays in addiction, but it really is more of discrimination. And one description is stigma is a social phenomenon whereby individuals who deviate from the accepted norm are perceived by society as less desirable and are judged or punished accordingly. Again, we see this played out in treatment and in recovery throughout the community. So why is this important? So remembering that we started with people matter regardless of what they are doing through. Stigma is the main reason that people with SUD do not seek treatment. Next slide. Again, talking about how stigma manifests itself. Self-stigma, family stigma, language, stigma in the medical community, stigma in SUD treatment, stigma in race, stigma in the legal system, stigma in the workplace, and stigma in the media. And again, I think this is a really important piece to talk about when talking about MAT, because we see this so apparently in so many different circles, even within the recovery community, in regards to also folks in the legal system, CPS system, employment system, recovery housing system. Some treatments take folks on MAT, some folks don't. So the stigma is truly ingrained. And so looking at how that manifests within the individual and within the community and within the treatment setting is an important piece to keep in mind. Next slide. Again, models of SUD dictates the approach of treatment and intervention, looking at the whole person, not just treatment as a moral failing, holding people accountable for immoral behaviors, and criminal justice. So these are just three components of looking at how stigma has been attached to addiction and SUD treatment. Next slide. The biopsychosocial model is a huge component of this, looking at the whole person, not just symptomatic pathologies. So understanding that addiction is a disease influenced by multiple irrelatable determinants. Prevention, treat, relapse, and support, and looking at the healthcare system. All three of these are interconnected. Next slide. Stigma of MAT and SUD. Again, looking at how those play out within systems and within treatment historically, and how it's been documented in research as well as what's been told to us by our clients. Looking at how stigma kills people by reducing the likelihood of their seeking treatment, how they're treated, what people say about them when they're entering treatment, when they're leaving treatment, what the community is saying about them. These things all impact, who seeks treatment, how they seek treatment, how long they stay in treatment. Treatment providers should model positive behavior by treating people with SUD like anybody else with a chronic health disease. Early on in treatment, educate everyone on the medical aspects of addiction to help focus on improved health related of the stigma concept of moral choice. Again, looking at more up-to-date biopsychosocial models of addiction compared to these past moral obligations, moral failings of addiction is a huge piece of understanding and changing the landscape of how we treat people with addiction and ongoing support for addiction. Educating staff and community about addiction and MAT. So making sure that your staff, your agency, your community that you're working within is knowledgeable on updates, best practices, content of what the language they're using, the images they're using, so that when folks do seek treatment and are in treatment, they stay in treatment if that's their choice. Again, reinforce confidentiality with patients and explain how you would interact with them in a public setting. Because we do not live in a vacuum, more than likely you will see your clients on the street. I know I have on more than one occasion seen people that I've worked with. So having those conversations and not just blowing them off in public as what that message may be perceived to them if they do see you and they are excited to see you and they want to talk to you, and understanding that you do have an obligation to them and their confidentiality. Again, this is kind of a baseline practical theory. And so I'm going to pass it back to you, Paul. Looks like you're back.
Yeah. Kashawn, do you still want to do the same slides? You want to do the slides for me?
It'll be easier if you get called away again. I can just continue to do them. Okay,
that'd be great. If you could do that, that'd be awesome. And then I'm going to pass this off to you in a second anyway. So one of the things that we're talking about, obviously, is medication-assisted therapy. If we could go back up. Yeah, that's what I need. Next slide, please. Thank you. So the big thing we're looking at, of course, with office-based opioid treatment is the use of buprenorphine, and it's typically done. We typically administer it when it's combined with naloxone and it's in the form of Suboxone. Actually, can you go to the previous slide real quick? There you go. The idea with this formulation, should the patient try to melt the drug down, dissolve it, what have you, that they'll actually, and they inject it, they'll be injecting themselves with naloxone, which is another name for Narcan, and that will go into withdrawal. I remember when Suboxone first came out, it was heralded as, yeah, this is a foolproof substance. People can't misuse it. Well, I mean, again, people find ways around that. The thing is that it is significantly safer than other types of medication-assisted therapy. And I'm not trying to knock methadone. I think methadone works for a number of people, and I think it should be more available in many ways. But the reason buprenorphine is safer is it has less respiratory depression than methadone. And it has effectively a ceiling effect, which means that above 32 milligrams roughly, it doesn't do anything more. So taking 45 milligrams is not going to do anything more than taking 32 milligrams. Most of the folks that we've seen in our clinics are taking somewhere between 8 and 20-ish, 20 milligrams. Some people in my old clinic were taking as little as 2. The big thing you want to be concerned about, but again, it doesn't mean that we deny treatment, is if people are concurrently using buprenorphine along with benzodiazepines and alcohol. Again, it doesn't mean that you don't bring them into treatment, but it does mean that bears closer monitoring. And we'll talk about benzodiazepines in a little bit anyway. Next slide, please. So the use of either chemical, methadone or buprenorphine, is medication-assisted treatment. And one thing we want to emphasize, and this is where I think that we have to do a lot of what Adam was just talking about with regard to stigma, and that is, to remind people who may not know as much about this work that neither of these chemicals, when used as prescribed, will get the patient high. Can they be misused? Yes. But when used as prescribed, it's not going to get them intoxicated the way heroin would. So sometimes you might have people say, well, you're just replacing one drug for another. And when I've had people do that, I've looked them in the eye and said, well, yeah, in a way, but I'm not going to argue with you. Do you want to understand the difference between these prescription medications, which are tightly regulated and where we know what the patient is taking, versus what the person is buying on the street that could contain any number of things, including various forms of fentanyl, which could very quickly be fatal to them. So do you want to differentiate between that? The big thing that we see is that the use of these chemicals, I am most familiar with buprenorphine, is that it allows the person's brain to heal from their misuse of opioids. It provides opportunities for the clients to address their SUD. Next slide, please. And just to mention, I mentioned naloxone. That is another name for Narcan. And it's used in an injectable form or intranasally to reverse an opioid, not opiate, but opioid overdose. Opioids include both opiates and chemicals that mimic opiates. So it can reverse an opioid overdose. The idea is to, if a patient needs this, is it buys time to get them to an emergency medical setting for further monitoring and possibly further administration of naloxone. Naltrexone is used by about 5% of patients who seek treatment at an office-based opioid treatment program. So about 95% use Suboxone, about 5% use naltrexone. Naltrexone, in many ways, is a deterrent, and it's an antagonist. And it basically blocks the effects of opioids and then to a much lesser extent, cocaine and alcohol. And so we are seeing that with some people, but the majority of folks tend to prefer the Suboxone. And then, Kishan, I think the next few slides are yours.
All right, I will be going over DMAS requirements to start an OBOT. So what is an OBOT and who can be an OBOT? All those are seemingly important questions. So an OBOT is an office-based opioid treatment provider setting. The different settings are primary care clinics, outpatient health system clinics, psychiatric clinics, FQHCs, which are federally qualified health centers, our CSBs, health departments, and physician offices. There is no separate license requirement in order to become an OBOT. There is an application process, which I do believe we cover in the next couple of slides. However, in order to be approved as an OBOT, there is an expectation to have a level of settings and supports. So your system supports include things such as access to emergency medical and psychiatric care and connection and referrals to the higher levels of care as needed for the individual members. Staff requirements, at minimum, there has to be a licensed buprenorphine waiver practitioner and a licensed behavioral health professional. Therapies in the OBOT setting, you include individualized and group therapies. Individualized therapy is patient-centered with assessment and treatment to follow. There is a maximum dose of buprenorphine of 24 milligrams, unless documented a rationale for the increase, and then you will have to have that approved from the payer. Also, the mono product is used only with a few exceptions. Medications for physical and mental health disorders are provided on site or referred out as needed. Cognitive, behavioral, and other psychotherapies are provided on an individual group and or family basis. Screening for HIV, hepatitis C, B, TB, and treatment for initiation is expected to be done annually. Care coordination with an interdisciplinary team is also expected to be done. It can be done by a treatment team, or you can hire someone specifically who serves as the substance use care coordinator that meets the staffing requirements for that individual. Risk management and adherence to monitoring is another important function within the OBOT setting. Routine and random urine drug screens. We do say a minimum of 8 per year. Urine drug screens are used to encourage to engage clients in treatment and should not be punitive. We do expect for providers to utilize the Virginia Prescription Monitoring Program at least quarterly on all patients. Opiate overdose prevention education and naloxone prescription for all patients should be taking place in OBOT settings. Patients will see medical and behavioral practitioners at least weekly for the first 3 months. And then with documented stability and maintenance, you'll see that those those 3 monthly visits become minimal to maybe once a month versus the 3. Those weekly visits will become reduced down to monthly visits. maintenance therapy for transferring existing patients do exist in the OBOT setting. What does that mean? So if you have a patient that is currently seeking or receiving treatment in another OBOT and they're deciding they want to switch to a different location and come to your OBOT, they are able to continue on with their maintenance treatment upon transferring versus having to start their treatment all over again. Periodic monitoring of unused medication, and open medication wrapper counts when clinically indicated also can take place within the OBOT setting. Now, when assembling your OBOT team, I quickly went over what the minimum requirement. So your minimum requirement is to have a buprenorphine waiver practitioner and a licensed behavioral health professional. However, there are other staff that can serve within the OBOT setting. Your substance use care coordinator, the CSACs, nurses, medical assistants, lab techs, pharmacists, and peer support specialists, which are highly recommended for the population that we're serving. Design time for team to work closely together. It improves individualized treatment planning, reduce patient ability to manipulate staff. Also, when looking at staffing, you want to look for staff who are knowledgeable about substance use disorder treatment, who understand SUD as an illness and not a moral failure. They're team players, and they manage difficult patient personalities well. Have I taken over any of your slides? I don't even know what number I'm on because I can't tell.
No, you're doing great. I think you got one more. There you go.
Okay, so setting up services. So referrals, you're looking at how do they come in, who's responsible for them, how quickly can you initiate treatment with new clients. So for referrals come from different places. Managed care organizations, they do track all the OBOTs, the regions and their locations. So when they get members in who are seeking treatment, they will call directly and make referrals to the different OBOTs for members. You also get direct referrals from the members themselves who are seeking treatment for services. So if you're thinking about starting an OBOT and you're concerned on where you will get members from and where you get referrals from, there is a process already in place that is currently utilized. Orientation, intake. So in the OBOT setting, the way your orientation intake happens will be based on your practice and how you set it up, but walk-ins or scheduled is fine. Also think about who is the first contact. Who is the first person that this member is going to encounter when they walk into your OBOT setting, because that can ultimately determine whether or not this member decides to ever come back and continue on with treatment. Is it open? Is it inviting? Is it warm? I would say, you have to make sure that your staff are avoiding giving their opinions about a person's treatment while they're doing intake and asking them what medication and everything that they're on. That should only be done by the medical and behavioral health professionals. So that way you don't have members who are already reluctant in some instances in seeking treatment, fear continuing on in treatment. And how are current clients able to access the program? Are you in a place, or are you advertised well? Are clients able to find you? Are you hidden? Like, how accessible are you to clients? Did you want to say something here, Paul?
No, I'm just nodding vigorously with you. I agree with you so much, and you're doing a great job of putting that out there. I like it.
All right, behavioral health assessment includes the ASAM multidimensional assessment. That is a requirement, but there are other types of assessments that can be done within the OBOT setting while members are coming in. You definitely want to make sure that you're getting the substance misuse history and mental health history of individuals while you're doing the assessments. Physical health assessments should also be done, which includes medication management, dosing, withdrawal management, induction, for new patients is required, and also induction for maybe patients who were in treatment and left treatment and decided they wanted to come back should be looked at again, and also required medical screenings. For risk management, when and how many drug screens are utilized? That's going to be based on individualized member treatment. You have to understand that you have to move from this one size fit all notion when it comes to treatment to it's patient center and it's individualized. One member may need 3 drug screens a week, where another member is further along in their treatment and they don't require as many. You have to look at things in your setup, such as which lab is going to be used, who handles your PMP monitoring, overdose education, counting open meds and wrappers. So all that should be incorporated when you're thinking about your setting and how you're going to handle all these different functions within the OBOT. You should also look at your channels of communication between teams. I think someone's unmuted. If you could please mute yourself. Thank you. You also want to look at the channels of communication between team members. How are you communicating with your team? Do you have it set up where you are communicating weekly? Are there weekly meetings, weekly team meetings? How does communication work? Is it consistent? Is it ongoing? Does every staff understand the expectations within that setting and are on the same page? Community supports. Will you require them? In my opinion, I think community supports are important and they help drive treatment, because what community supports does is it allows the member to be heard and say, hey, I have these things that I also want to take care of outside of my treatment. Are you there helping to make those connections and assisting the member with those? All right, and pass this back over to Paul, I believe.
Yeah, you got it. Thank you. So the big thing we want you to talk about is we know we're giving you a lot of information here. The best way I can look at this or explain this is having been a part of getting an OBOT from basically a pilot phase into a full-blown phase is just go. I mean, go slow, but go. And the thing is that you know your clients better than we do. You know your treatment setting better than we do. But, try things out. So take the requirements that Kishan just talked about and some of the examples of functioning OBOTs, because Adam's going to spend a fair amount of time, second part of this training, talking about contingency management using peers and all kinds of cool stuff like that. Take what you think you can do and try it out. And I think that's just really important. Next slide, Kishan. And the slide after that. So the big thing we want to look at when we talk about treatment is we want to remember that people with SUD may engage and disengage in treatment during their illness. But because a person disengages, we don't necessarily consider that a treatment failure. Things happen. Sometimes it's, a client may get a show cause issued against them and wind up, being put in jail for 3 months or something like that. There's an interruption in treatment there, or other things can happen. But one of the things I've always reminded my clients about is, treatment knowledge can be cumulative. Therefore, the back and forth pattern should not be viewed as treatment failure. Next slide, please. What I want to talk about, though, is I want to really build off on what Kishan talked about there in terms of put yourself in a client's shoes, standing in front of the doors of your clinic, and what is it that they see? So whenever I did an assessment on a client, and Adam and I worked at Daily Planet Health Services for several years in the OBOT program there, is I would always ask my clients, if I was doing an assessment, what brings you in today? And usually my second or third question was, why today? And it wasn't meant in a way to challenge them or to be like, in a negative way, but what was it about today that made you walk those 6 steps? And I knew there were 6 steps because I counted them. Because I stood outside several times and say, what would it mean to be a client who's desperate to walk in this building? What's the first thing they're going to see? What does the room look like? Is it inviting? What about the people behind the desk? Are they inviting them? Are they knowledgeable? Does somebody greet them as soon as they walk in the door? And luckily we had great, and I believe they still do, great registration staff, people like Freddie who can say, hey, I see you. Basically, I see you as a person, because so many of our clients with SUD are used to people looking through them. for seeing them as invisible. This is important. So we want to create an inviting atmosphere. And what I found with that when I was the head of behavioral health was to spend a lot of time, comparatively speaking, with registration staff to provide them with answers to questions that they would have about treating people with SUD. Now, they've been treating people with SUD since the clinic's doors opened 50 years ago. They knew that. But they wanted to know more about what we were doing in the clinic, wanting to know about our success stories, wanting to know about our challenges, but also knowing I wanted to create an environment to where they could ask a question of me, not just as a manager, but as a clinician, and know that they could get an answer. And that was important. So we really want people to be on board with this. And that inviting atmosphere isn't just with your frontline staff, but also even with your administration, with your board. People need to be on board with this. When folks say to me, and Kashan and I have done this presentation, or an iteration of it, I think 3 times. And one of the things that people have said to us when we've done this before, we've done it live, before COVID, when we could actually be in the same room with each other, was, there are people in my clinic who say, well, I don't want those people in our clinic. And we're like, yeah, those people have been in your clinic all along. I mean, SUD is one of the most prevalent disorders that we're going to see in both the medical field and the mental health field. And of course, we know that those two fields, the better they're joined, the better the job they do. But that inviting atmosphere cannot be overstated. Next slide, please. One of the things that I really will challenge you to do is when you look at an assessment, and I'm a big fan of assessments. So a comprehensive assessment of the patient is critical for treatment planning. However, this is important. Completion of all assessments should not delay or preclude initiating pharmacotherapy for opioid use disorder. I'm a big believer that assessment is ongoing. I also believe I don't need to know everything about a person's problem, in order to help them. And a lot of time, and what we found in our clinic is, as we went from pilot to full online, fully rolling, is that we couldn't wait for treatment. And we moved to a model, and it did take some shifting of priorities. It did involve changing a lot of things that we did, but it wasn't as heavy a lift as we thought it would be. It also meant hiring some extraordinary people and then letting them exercise their strengths. But one of the things we saw was that we wanted to have same-day treatment. We wanted a person to be able to walk in most days, maybe not every day of the week, but I think we originally shot for 2 days a week, and then eventually became, I think 4 out of 5 days a week, to a person could be seen and could be started in treatment, because we didn't know what that person's situation was going to be the next day, or when they're going to another clinic, or whether it's an FQHC or a CSB or anything like that, and they're being told to come back in a month. No such thing. So the thing is that we have to take a look at our systems of care. So what that meant was, from a clinical standpoint, I wanted to get the information I needed. I wanted to know about the history of the presenting illness. I did want to assess for suicidality because of the comorbidity between suicidality and opioid use disorder. Very high comorbidity there. And there were other things that we wanted to assess: the person's capacity to consent to treatment, and obviously a medical screening as well. But in terms of going into a deep dive into social history and things like that, that could wait. That could wait until the person is stabilized. And so that took some changing on our part. It took some mindset changing, but it also took a different way of dealing with this. And so what we were doing was aligning with ASAM recommendations. Next slide, please. But the American Society of Addiction Medicine has 6 dimensions of assessment criteria. First of all, we want to look at, does there need to be acute, do we need to look at acute, is a person acutely intoxicated? Or is this something, if they're the withdrawal profile, for example, if they're using heavy amounts of benzodiazepines, or even more problematic, alcohol? Does this person need to be seen in a supervised setting for detoxification or withdrawal management, is the actual term. we want to take a look at any biomedical conditions and complications. We want to make sure that we're assessing for physical health conditions. One of the things I've always told my students at the university level is, when you're doing an assessment, you must always ask yourself, what could kill the patient first? And that's true. There are a lot of things that appear as a mental health or even an SUD issue that are, in fact, related to physical health. Next slide, please. We want to, basically assess and treat any emotional, behavioral, cognitive conditions and complications. We see this especially with a high degree of comorbidity with trauma and SUD. We also want to assess their readiness to change, understanding that a lot of our clients are going to be ambivalent or even guarded about changing, and that's okay. We don't need to wait to initiate treatment when the person is 100% full on board, ready to go. We can initiate treatment before then. Next slide, please. And the last two, we want to assess and try to limit any harm related to relapse or continued use. And Adam's going to talk about harm reduction and some other aspects a little bit later today. The big thing we also want to look at is our recovery environment. One of the things that we had to see a lot with our clients was, does the person have, a place to live? Do we need to coordinate housing services and other services like that? We want to try to assess what's called their recovery potential. I did see a question. I'm going to catch it when we have a breaking point soon. Next slide, please, Kashan. And so one of the things that we want to look at is how we induct or how we begin medication. So when OBOTs were originally set up, medication was almost always started in the office setting. As providers became more comfortable with clients starting medication, the pattern shifted to home induction, which is an evidence-based practice at this time. You don't need to have the client induct in the office. We never did at the Planet, and I don't believe we ever had any problems with induction. So following assessment, the medical provider does their assessment, writes a prescription, which the client fills, and the client then starts taking the medication. But we counsel them, and this is where we would use our peer recovery specialist a lot, counsel them on when to take the medication, so that we wanted them to start taking the medication when they felt the withdrawal symptoms. And so this is where it was important to have that collaboration, that buy-in with the client. And what we tended to do was our prescriptions were electronic, so they would just go straight to the pharmacy of the patient's choice, and we were only going to send them to one pharmacy, and that cut down on a lot of issues. Next slide, please. And then another component that Kashan talked about, particularly in the first part of treatment, is the need for behavioral health therapies. Now, some clients are going to be adamantly opposed to this, and the ASAM guidance on this is, we shouldn't deny a person access to, medication-assisted treatment because they don't want to do behavioral health. Okay, that is their guidance. There are some papers out there, some research that says, that behavioral health it doesn't make a difference. I tend to question. I'm not questioning the people that write those studies. A lot of the studies I've read, the people writing them are not behavioral health folks. I think it's about the quality of the therapy, though. And really, what we do know from decades of research is that the quality of therapy is dependent upon the person delivering the therapy. And what our clients want to know is two things. Does the person who's working with me, are they competent? And the second thing, and even more important, do they care about me as an individual? Now, obviously, it's more than caring for people that makes a good therapist. But I think that those two things are extremely important. And so I see a lot of benefits for the psychotherapy standpoint, particularly when you look at the high degree of comorbidity with trauma and, to a lesser degree, other mental health issues. And so I think that this is a really important thing, and it can be group or individual therapy. Notice it's weekly for at least the first 3 months, and then minimum monthly after that, but it can be more. You can design your program differently. There's a lot of leeway here. Groups can be process-based. That's the groups that I tended to run at Daily Planet. Adam ran them too. We also have people that did skills building groups or a relapse prevention group. And, can also I provided psychoeducation within a process setting. I tend to like doing groups. Some programs use a phase system that has clients start with weekly or more contact with the clinic. And then so they might go to group once or twice a week at the beginning. What I recommend you do is try to have it so that behavioral health contact with the clinic occurs the same day that they see a medical provider, because it limits the stress put on the client. But you may start out with 2 contacts per week and then go to 1 contact per week and then onward. And there are clients who that I've worked with who, after a year of being in therapy, a year or so, as Kishan said, it's different for every individual, that may go to just medication only. Try to understand that this is a complex issue and treatment should be individualized. Next slide, please. Oh, this is you, Kishan. This is you. Ipocs.
Yeah.
Yeah.
So treatment planning. So within the OBOT setting, there are requirements for treatment planning. You have your individualized ISP, which is required to be completed within 24 hours of admission to the OBOT. It is technically your roadmap to your Ipoc. It addresses, the health, safety, welfare, immediate needs of the individual upon the first contact and initiation of treatment for them. So as they continue on in treatment, and let me not skip this part. That should be completed by a credentialed addiction treatment professional and be based on a SAM multi-dimensional assessment done at intake. Now, as they continue on in treatment, you then want to develop what is your Ipoc. That should be completed within 30 days of the ISP by the credentialed addiction treatment professional. And it should be reviewed every 90 calendar days. Now, with your Ipoc is required if you are billing substance use care coordination. You should also be looking at written representation, excuse me, I got tongue tied there, of the interdisciplinary team doing your different treatment meetings when you're looking at updates to your Ipoc. Now, during the time frame where you're required to make an update with the Ipoc, which is 90 days. So let's say at day 45, you and the interdisciplinary team meets and you're discussing treatment, and you see that a member, maybe they're not progressing on a goal and you need to change your treatment for that goal. You can then you should be doing progress notes, and things like that should be documented in your progress notes. And then you can do addendums to your Ipoc. You don't have to do a completely new Ipoc just because a treatment goal changed. At your 90 days, if nothing has changed in the member's treatment and you don't need to make changes to your Ipoc, then you note that as well in their progress notes. I say all that to say we are not looking for this Ipoc to be this strenuous process that takes you forever to do. But it should be detailed and explain the treatment options for each member, again, individualized based on each individual member's treatment needs. Let's see. Also, if you are completing your Ipoc because you're billing for substance use care coordination, that does replace the need to then do the comprehensive ISP. You don't need to do 2. The Ipoc will serve as that. Right.
I think it goes back to me now.
It does. So I don't know, Paul, do you want to, we're like halfway through. So did you want to take a break here?
Let's take a 5-minute break. Let's come back at 2:06. And so folks, take a 5-minute break. We'll come back at 2:06. And I just want to talk about drug screens and then kind of hand it over to Adam to talk about some really cool things you can do in your OBOT. So we'll see you in 5. Okay, folks, in the interest of time, we're gonna keep rolling here because we do have a lot of content to get, and I do want to answer some questions at the end. Kishan, you still with me?
Yeah.
Okay, can we go to the next slide, please? Thank you. One of the biggest questions we get when we talk about OBOTs is urine drug screening, and part of it is because for such a long time, urine drug screening has been a rather ubiquitous part of drug treatment, right? And so I did want to just say a little bit about this, and then I'm going to transition it over to Adam, and hoping that he has audio. So the big thing with drug testing is to ask yourself, why do we drug test? So we want to remember, excuse me, that no form of drug testing is 100% accurate all the time. No drug test, and the drug testing can be a part of the therapeutic process, but it should not be used punitively in therapeutic settings, particularly in OBOTs. From a therapeutic standpoint, drug tests can be used to verify the client's transparency and provide opportunities for more effective treatment. And I gave you an example there of a kind of a compressed, not dialogue, but something I said to a patient at one point. Next slide, please. The whole thing is that, with drug screens, we typically use urine because they're the cheapest and easiest to use form of drug testing. Before you do them, you need to have a testing protocol in place for your agency. Now, we want to be mindful that urine drug screen has limited value if the patient is not directly observed giving the sample. However, what I have found is that can be something that pushes people away from treatment. So I think you have to look at what is the value of this. So when we were setting up the Planet system, the Daily Planet system, we talked about this because I had worked in a drug court program where people were observed, but there they were under a very rigid, legally based system where there has to be a clear chain of custody of that urine, essentially. We quickly decided that was not us, that it was going to require a lot more staff involvement. It was going to also be in some ways humiliating for our clients. So we decided that we were not going to do direct observation, which meant that a urine drug screen is not the only way that we were going to measure a patient's position or progress in treatment. And I think that we have to be mindful of that. Our doctor, Dr. Popovich, who's our medical director, mentioned one time saying, we could also look at, physical presentations, pinpoint pupils that are unreactive to light. Does the patient appear to be somnolent? Things like that. But even in those situations, the idea is to have a conversation. I'm not in a position of trying to play gotcha or anything like that. Next slide, please. We also want to remember that the point of care test, that's the cup test you saw the slide a few slides ago, use antibodies to locate metabolites of drugs in the person may have used. And the possibility of a false positive or a false negative can be high depending on the substance that's being investigated, or any number of things. So one thing I would encourage you to do is that you don't want to make any treatment, or in the case if you work in the legal system, never make a legal decision based upon a point of care test alone. It should be verified by a lab. Next slide, please. And our lab tests utilize, here we go. Basically, the industry standard is the gas chromatography and mass spectrometry combined. It's very sensitive. It's very accurate. It is more expensive, obviously, than a point of care test. And it can provide levels. And so one of the reasons I included this is I had somebody in an OBOT ask me, says, hey, the lab is just telling us that the level is 3,000 for amphetamine. Is that positive or negative? And I said, well, you need to determine what is a positive level in your program. Most labs are going to establish different cutoffs. So the way that we did this in the court system, for example, was there was a cutoff of 50 nanograms, or 50 milliliters, nanometers of nanoliters, of THC. So if a person's THC level was 40, it's negative. If it was 60, it's positive. Those levels can go up and down whether the person is using or not, because a lot of it has to do with metabolism. So if you're going to say, okay, this is our cutoff for this particular chemical, it needs to be read as either a positive or negative screen. But again, with the lab testing, what I would mainly use these for an OBOT is to make sure the client is taking their Suboxone. And so you're going to want to test for the presence of the buprenorphine, but also to test for the presence of norbuprenorphine, which is a metabolite, which shows that the buprenorphine is not just in their lab sample, but it's actually their body is breaking it down. And I think that is important. Next slide, please. Next slide, please. Other challenges you may face, and that's continued use of substances. And I think that's the biggest challenge that our OBOTs face. We have to see recovery as a process. Therefore, stopping misuse of opioids could take time. The whole idea that a person's going to come in and stop on a dime, I would really like that to happen a lot. The reality is, if I based, if I use that as a criteria for continue treatment, I'm going to discontinue treatment for a lot of people, and we know that that's a worse outcome. We do want to conduct regular and random urine drug screens as a way to to have it be a part of a treatment discussion. You do want to limit tampering. Limit the possibility of tampering sample. There are ways you can do that, and Adam and I can talk with you about those further if you're interested in that type of assistance. The biggest thing is I want to encourage transparency with clients. And extra support after if there's a relapse or return to use. And the big thing is you don't want to have a specified limit of positive screens. So 3 positive screens and you're out. That's just not, I don't think that's useful. The treatment team should see continued use or continued positive drug screens as a sign for a need for possibly a higher level of care and refer the patient out with the opportunity for them to return when complete. But if you do refer a patient to a higher level of care, maintain them in your level of care until they are able to make that transition. The ASAM criteria about levels of care are fantastic. The big problem is that we don't always, and I would say most of the time, have access to readily available different levels of care. And we've seen it even more so during the response to COVID when everything kind of shut down. So again, we may have to maintain that client and work with them the best that we can. Next slide, please. The other thing we want to look at is client relationships and be cognizant that could happen. We do want clients to be a support of each other, but romantic relationships are going to happen. And so again, we always did was encourage people to be honest about that. And so if we had 2 people that developed a romantic or a sexual relationship in a group, we're going to put them in separate groups. And we're not doing that to be punitive. We're just doing that to say, hey, it's in the best interest of the group. It's hard to be completely open when you've got a person in there that you have a relationship with outside of the group. What we found is when we had that conversation with folks, a lot of times they'd be like, yeah, I want to be able to talk about my partner, without, if I'm frustrated with them, I want to be able to talk about it without them sitting there. Next slide, please. And then, one of the other things is not taking the prescriptions. So testing negative for Suboxone while the prescription is being filled means that they may be diverting their medication. So we want to check in to make sure the client's taking it correctly. And it may be that it's a need for a higher level of care. But I think that's why it's important to check that prescriptions monitoring program and to do drug screens, particularly in the earlier parts of treatment, because I don't want clients diverting the medication or trading it in on the street for heroin. Next slide, please. So if a client is terminated or discharged, the decision should be among the treatment team, and we should be facilitating or handoff to another program or to a higher level of care. There are exceptions to that, unless violence or other presenting issues as mentioned below. Next slide, please. Don't be too quick to discharge patients. Again, so I want to emphasize, see continued use of a substance as a possible part of the client's illness. Some clients, some programs have said we're not going to bring anybody in that's using benzodiazepines. People can be started in an OBOT program with utilizing benzodiazepines, and then gradually tapered by a qualified medical provider. We need to remember that recovery takes time and relapses, like most chronic illnesses. There are times when discharge can be considered, and I do want to mention this because I don't want to make it seem like I'm saying you can never discharge somebody. I think violence or threats of violence against staff or patients can warrant discharge. Even then, I had to do that to a patient one time in my last clinic. I still said these are other programs you can go to, but he had actually assaulted his partner who was in the program, and that was simply unacceptable. Bringing illicit substances onto clinic property, that's simply cannot have that. And in other cases, repeated incidents of not following program requirements after much encouragement and support. Again, I think in those cases, it warrants a higher level of care. Next slide, please. I'm going to I think this is a great place to turn it over to my teammate, Adam. Hopefully he's still here because he's going to talk about community resistance. And he's going to talk about some really cool stuff that he's got going on as well. Adam, you with me?
I'm with you. Can you hear me?
I can hear you.
Well, that's beautiful. That's beautiful. So kind of touching again on what Paul was talking about with community resistance to MAT. Now, the messaging is imperative to have a clear, articulate structure laid out so folks know what they're signing up for when they walk in the door. A lot of times at the clinic that we were at, we would give the contract to the client so they had it. They had a tangible copy with them. That way, if there's questions or discrepancies, there is a point of contact that is tangible. Also, emphasizing the risk management strategies used by the OBOT. Part of the OBOT is trying to make a consistent and inclusive environment, being aware of your gaps, and taking in consideration, clients as well as other staff members' feedback, surveys, those things help. Paul was on fire with sharing the message at the Daily Planet with the media, newspapers, as we saw in the Vox article in 2017. Once Medicaid expansion went live, there was a full, 4 to 6 page layout on what MAT and a qualified federal mental health system looks like. And so it's great to have that stuff on hand. It's great to be able to have that information to share with your development staff. Again, these are all tools that can go into when we talk about the contingency management piece later on in the slides. It's important to bring in the communities at large. The faith-based communities are a huge ally in regards to building a strong support system for folks. Folks are only in treatment for a very small period of time throughout the week, so being able to tap into those other outside resources, those other communities, and bringing them into the fold is definitely imperative. Next slide. Next slide. So what we saw a lot of times when folks coming into our program is that they hadn't been seen by a provider, a medical doctor in quite a bit of time. And so over a period of time, we were able to create a piece of our MAT program that did not mandate, but highly, highly suggested getting physicals for folks to be aware of their status. If they have HIV, if they have Hep C, if they have hypertension, if they have other comorbidities to know about ahead of time. That way we're able to work on those in-house if possible. Not all OBOTs have, PCPs on staff. They have the full continuum of care within their organization, but if they do, be able to provide those warm handoffs and referrals, really streamlining the whole person and not just looking at symptom management. Again, for a lot of folks coming into treatment or getting in recovery for the first time, there's years of, neglect in the sense of health, wellness. I can't tell you how many times I've had folks tell me that they've had to pick up because they've had an abscess or because their tooth was infected. And so trying to build those skills and provide resources, if you have those things on hand internally, is huge. We created a kind of a small handout that would hand out to folks that didn't have access or resources for dental services. So they know, they can go to CHIP or they can go to these other hospitals and get immediate medical help with dental issues if it's infected or other things like that. Again, as it was talked about before, it's hard to focus on your recovery if you're sleeping outside. It's hard to focus on being treatment adherent if your housing is in shambles, or if you're not sure where you're going to sleep the night before, or if the people you're living with are actively using. And so taking into consideration what other resources you have internally, as well as building community and connection outside of the agency, is a huge part of having a nice cohesive system of care. Next slide. As Paul mentioned, the interdisciplinary team is a regular part of this piece. We used to have, team meetings twice a week in regards to each clinic. A lot of times it is imperative to bring that individual into the meeting. It's imperative that everyone's all on the same team. I'm not a big fan of the word, client splitting, but it is imperative that everyone is on and informed of what's going on with that person's treatment of care. That way one person is not getting fed one story and someone else is getting fed another story. That way you have a streamlined approach, all hands on deck kind of a way. And going back to that, when you're doing groups, bringing other folks into the fold, bringing in the pharmacists, bringing in other providers that may be able to answer questions about concerns or issues that the client just doesn't know how to inquire about. Again, it's imperative that this is consistent. When this falls off, it's hard to maintain cohesiveness among your team. It's hard to maintain cohesiveness about making sure that you're matching the goals and that the milestones along the way are also being met. And so making sure that this stays part of your regular schedule is definitely imperative. Next slide. Again, talking about higher level of cares, what one person sees may not be what another person sees. And so having those conversations, tracking and supporting the patient services outside of the OBOT is also important. And again, if other higher levels of support are needed, knowing what those resources are, having contact or having a gatekeeper at your CSB or another social service to be able to tap to refer is an invaluable service. Next slide. And so we're moving more towards peer recovery services, as well as looking at what that means. This is a definition from SAMHSA. There's a bunch of different definitions in regards to what peer recovery services is or what recovery is. I just want to highlight that recovery is also independent of treatment. A lot of times the word treatment and recovery are interchanged, and the way I view that is that there's separate intervals in regards to prevention, treatment, and recovery, because recovery is looking at the whole person over a longer period of time, and treatment typically has more of a symptom management, short period duration, a beginning and end, versus recovery is a whole process. And so once again, this is SAMHSA's definition. I'm fond of this definition because it looks at the whole person and brings in the other considerations of the biopsychosocial, the wellness of the person, just beyond, is this person absent? Is this person not abstinence? But looking at wellness. And so I think this definition is definitely important to be aware of. Next slide. And so looking at your systems when thinking about implementing peer services or bringing your agency within the fold and changing what it looks like from a disease model to recovery model, there's a lot of research on this. There's, William White is a huge academic as well as an empirical writer that talks in length about what a recovery-oriented system of care, and that goes beyond, doing lip service for what, person-centered and self-directed approach look like, but really honoring, multiple pathways, looking at the whole person and bringing into the fold what that means. I think it's important when you're looking at, the person-centered. Can we go back, please? Thank you. So when you look at looking at the person-centered, looking at, is the person's choice, is there flexibility in regards to their treatment? Is that provided in the care? Are we pathologizing? Are we looking at, deficits versus strengths? These are all values and these are all philosophies that help strengthen a program and help strengthen an agency to really provide a holistic approach to healing a person. And so just kind of building on that in regards to these three first bullets. Next. So again, looking at bringing the whole community in regards, addiction doesn't necessarily just end with one person, but looking at the family, looking at the community, looking at other allies in the community that may be able to be brought in, inclusive, educated. That way when the person goes home or when the family moves on, there's support, there's resources, there's education involved. The collaborative decision-making is an essential piece to this, making sure that the individual's voice is heard, that if they have questions, if there are concerns, if this medication isn't right for them, having space to be able to explore that, talking about pros and cons. Again, bringing in, a complete picture of what this may look like. For a lot of folks who come into treatment, they may have been in treatment before, things have changed, policies change. As we see now, just the whole landscape of addiction has changed within the last 20 years. And so really creating a space to explore what that looks like. Next slide. I think this is a big piece to really hit on. When integrating peer services or bringing folks on to your agency that may have experience with SUD or mental health challenges, the microaggressions, the tokenizing, these are all things to be aware of. These things are a lot of times ingrained, and they may be subtle and not, well known within, congregating, social norms, agency functions, but things to be aware of. As a person in recovery, if there's a holiday party and there's an open bar, that may not be something they feel comfortable going to. Or hiring someone that's in recovery who's always your spokesperson to talk about, treatment all the time is not necessarily setting that person up for success. Hiring a person in recovery but not allowing them to have access to the computer system in the same way another trained individual would have access. These are huge parallels that we saw at our agency, and I've heard across the continuum of the state when I used to go around talking to other peers. How are we setting folks up for success? Are we allowing them to come into the fold, or are we allowing them to come in but still kind of shutting the door and being aware of what those biases are, and potentially maybe even having to alter what your agency, your HR policy looks like? With that last bullet talking about hiring individuals with criminal record. If it was not for my criminal record, I wouldn't have found recovery. And so it's kind of a paradox to think that one thing's an asset, but another thing's a deficit. And so really looking at what that means, because is your agency allowing second chances? Is your agency looking at how people change, adapt, and mature over time? Because what someone did one day does not define who they are and how they live their life. And so really kind of being aware of what these biases and what these norms may look like conscious and unconsciously in your agency. Next slide. So you may already have folks, you're looking to start an OBOT, you may already have folks that are within your agency that would be great champions. I know when me and Paul worked at the Daily Planet, we had a few folks that, they had done well and they had achieved what they wanted to achieve, and they wanted to help other people, and that's great. And so if you're able to tap resources and expertise already within your agency, that's a huge asset. I think also being aware that just because the person's in recovery doesn't mean that they would necessarily be a good peer recovery specialist, or using their story, because it's different for everybody. Everyone's different along their pathway, but understanding that you may already have talent within your agency and potentially having to create a pathway to hire or change HR and fulfill those positions. Paul, you kind of talked on recovery language. We hear this. Recovery language is pretty ingrained in addiction treatment, ingrained in recovery circles. When I hear the word addict, I have a visceral response to it. And so understanding what, words have meaning, words have power, and what one person describes themselves in the recovery community versus what treatment providers tell them or label them, there's implications attached to that. And so being cognizant of that. Keyshawn talked about the atmosphere. At the Daily Planet, we were fortunate enough to be able to create a new atmosphere for the recovery. We modeled a space after a living room model, so folks had a space to feel comfortable. This wasn't just a waiting room. This was a space where they can engage with their other peers. They can kind of let themselves feel at ease, have a cup of coffee, talk to a peer recovery specialist, talk to someone else in the group, but allows them to space to heal, to hear hope, to feel resilient. and build that community. I can't emphasize this enough. If you're able to create a space within your agency that allows and builds on people's resiliency, it's a huge piece to this. Next slide. Again, another definition of peer recovery specialist, because we're working within OBOTs or talking about OBOTs, understanding what that looks like, understanding that different agencies, different states have different terminology when it comes to peer recovery specialists. This is kind of the foundation when you're talking about evidence-based practices and looking at peer recovery specialists, looking at what they do and what they don't do. We hear this all the time. You know, we think they're not many case managers, they're not therapists. Understanding that there's a role, understanding that there's a scope that goes with that role is a huge piece of, you know, building an agency and builds a culture that empowers and lifts up their staff and is aware of what it is and what it isn't. I can't emphasize this enough. And so if you're not familiar with peer recovery supports or what this, you know, service looks like, I would highly encourage you to do some research on your own. Again, there's a plethora of information out there about what this looks like. If you have access, Department of Behavioral Health and Developmental Services has a website that highlights what is, what isn't, and just lays things out nicely from a state perspective. Also, SAMHSA has a slew of information on this that I would encourage you to check out if you have not already. Next slide. So talking about peer recovery specialists in regards to, you know, how they work and what they do and what they don't do. You know, there's a litany of research that talks about the benefits of peer recovery specialists, how they improve agencies, how they improve culture. And we're talking about, you know, reducing inpatient services, improving relationships among providers and patients, sustaining engagement in care, increased levels of resiliency and empowerment, higher levels of hope and recovery outcomes, higher level of patient participation and treatment, additional goal attainment after treatment. Again, these items are all well documented, and there's a litany of information that talk about just how vital peer recovery services are and what they can do to your agency and do to your treatment modality if given the opportunity to really advance and you know, adjacent to other therapeutic services. And so there is a high value in bringing on someone that has lived experience, who's been in treatment, that knows what this looks like, what this doesn't look like. You know, there's a saying that says, you know, seeing is believing. And for me, I had no idea what that looked like before I got into recovery. And so having someone model what that looks like goes a long way. Next slide. Again, additional benefits when we're talking about, you know, the new current evidence in peer recovery services and how that transcends to the current opioid epidemic when we're looking at, you know, bridge capacities from, you know, folks at overdoses to emergency rooms to treatment to outreach, you know, the touch between going to a hospital, not going to a hospital, what that looks like if a person is justice involved upon release, involvement while incarcerated. There are places in Virginia that have peer recovery specialists within the justice involved populations, and the outcomes are promising. Again, being able to have that warm touch to be able to talk about, you know, harm reduction services. Again, this is a word that's very taboo in some treatment circles, but again, this is a life-saving, evidence-based approach that for a lot of folks, having a peer to be able to, you know, have that warm hand and explain what Narcan is, how to use it, where to get it. You know, in regards to needle exchange services, hepatitis C, HIV, these are all services that can be improved and built upon with having someone that has firsthand experience and that knows about natural support, so things outside of the treatment setting. Next slide.
Oh, can you take over presenting for a moment?
I'm sorry?
Can you make me the presenter? I gotcha.
Thank you.
Yeah. Hang on, Adam. Let me get to the right slide. Adam, you were on this slide, I believe.
I believe so, yeah.
Fantastic.
On to the next.
All right. You want the next one?
Yes, please.
How's that?
Beautiful. So
I know.
Again, more evidence, more research backing up these claims, so it's not just my word. There is a litany of research that documents and explains how peer recovery services have a lasting and important impact on folks. Pre-trial, post-trial, incarceration, pre-treatment, post-treatment, that warm handoff outside of treatment, building a community out in the community. There's a long line of entry points that can be utilized if understood and successfully put into place. Next slide. So in Virginia, when talking about implementing peer services, this is kind of a rough outline of what that may look like for folks that want to bring on someone who's a peer recovery specialist, not sure what that means or what that entails. Similar to other professions, there is a criteria, there are standards, there are code of ethics, there is testing, and these things are continual. And so understanding that there is a wealth of knowledge and experience that's coming with that person that you're hiring. And so in Virginia, there is a set of standards in regards to completing a 72-hour training by DBHDS. Once that is completed, you have 500 hours of field experience you must complete, and you apply for certification through Virginia Certification Board or NADAC, which is the National Association of Alcohol Drug Addiction Counselors. Again, there are standards, there's ethical considerations to be taken into consideration. And if you're going the route of billing, that person then applies to the Department of Health Board of Counseling. Currently, there are scholarships available for folks that want to get certified, and that information is on Virginia Certification Board. That information is time limited. I definitely want to speak to the part about who's going to be supervising the peers, because this is a big step in regards to setting that person up for success, the flow of services, and looking at how those services can be expanded down the line. And so making sure that your trained professional, whoever that may be, can be a peer recovery specialist with 2 years of practical experience, or CSAC, QMHP, and a clinical, getting their hours, whatnot, making sure that person has a wealth and base knowledge of what recovery is, what treatment support is, and they're able to provide and share that. I can't tell you how many times I've heard about folks hiring peers and not knowing what to do with them, or hiring peers and the peer becomes a greeter at the door, and that's their only task. And so really understanding that peers have a scope, there is a code of ethics, and there are things in line to match their skill set up with what your agency is looking to complete with that. So I highly encourage you to look into that. Again, that information is provided at DBHDS's website on the Office of Recovery Services. Next slide. So another important piece I want to speak on is the piece of peer recovery services being voluntary. And so services forced on folks forced to work with a peer recovery specialist slowly deviate and are moving away from what evidence-based practices talk about, the holistic and the wealth of knowledge that peers bring to that equation by being voluntary. And so there's articles at the bottom, there's articles before talking about how, keeping this practice voluntary has long-lasting implications. And so really being aware of that when you bring the peer on, they are an adjacent service, but they're also a volunteer service. And so forcing somebody to use peer services actually has the opposite effect. And so this is part of them being their ally to that individual, to that client. So they have someone that is on the same level with them. There's no hierarchy here. And so really being aware of, if and when you do implement peer services, what does that look like? Again, tracking the data in regards to the story you're wanting to tell. This goes back to development. This goes back to sharing what your agency is doing, what's working, what's not working. There's narratives, there's success stories, there's a wealth of information that you can use to really tell the story of what people are doing in your agencies. There's places like Faces and Voices in Recovery that have platforms that can help you with this. There's agencies already out there kind of doing this, so you don't need to start from nowhere. Again, talking about internal trainings, bringing other staff, other leadership up to speed on what is and what isn't peer services is a vital practice. By being aware of the role, being aware of the history, and being aware of how this may change services or change practical, structure systems is a huge piece and can be beneficial to your agency. I know when I was at the Daily Plan and we started doing peer services, there was a lot of bumps along the way because folks didn't know what it was. Folks didn't know how this was different from something another service. And so really having that conversation, having those trainings to bring people up to speed, encouraging folks to do their own research if they have biases or questions is essential. And then again, talking about the scope, the practice, core competencies, matching your job description, matching HR requirements can be a huge piece to setting people up for success. Next slide.
Real quick, Adam, before you go on to the next thing, I just want to add a comment that we have in the chat here about the recovery specialist. Is that okay?
Sure.
The participant, what she said was just so spot on. She notes that the worst thing she's seeing is barrier crimes that are being held against people in recovery. She notes that she hired a woman who had been in recovery for 8 years, was peer certified, but needed her 500 hours signed off. This person was a former teacher, and she ended up leaving the company because they couldn't get her credentialed as a peer recovery specialist, even with all the educational milestones met, because of the the barrier crime stuff that you talked about there, and just the irony that it's sad irony more than anything else. And this is something that we are trying to make. By we I mean Medicaid and other people are trying to make headway in getting some of the laws changed in the General Assembly. But it's another it's another barrier toward people in recovery. And I just thought that was a really good point.
No, it's a very valid point. I know, speaking with Ballard Health, when they implemented their first peer recovery specialist, their executive director had to go to HR, had to go to their leadership and say, hey, I want to take a chance on this person. This person has this background, but look what they've done since, and look who they are now. And so I think if you're able to take that chance on that person, I highly encourage that. There's also information on if the person wants to get certified. There's a question about felonies. I would encourage that person to at least still try and not be discouraged by that, because there is room. And a lot of times, I think when you see that, you automatically close, you shut the door and you move on, but there's still a chance to open that up. And so if you have someone that is interested in getting certified and they're concerned about the felony option, to still apply and write a summary about that, it's worth a shot.
It's a really good point. I'm going to go ahead to the next slide for you, man.
So
actually, we're going to pass this off to Keyshawn to talk about this.
Yes, I also want to just be cognizant that we have about 15 minutes, and I think we still want to save at least 5 at the end for some questions. So I will just go through this fairly quickly. So this talks about the recovery, resilience, and wellness plan that is required for peers. It is an individualized goals and strategies should be included in this plan that focuses on the members' identified needs for self-advocacy and recovery. It should be developed with the individual, a guardian, the peer recovery specialist, and direct supervisor within 30 days of the initiation of services. And it should describe how the PRS will assist the individual in meeting their individual goals. It should be reviewed and signed every 90 days as applicable. The review that's done should look at things such as changes in the member's recovery, as well as any newly identified needs. It should be conducted in a manner that enables the member to actively participate in the process and be documented by the PRS in the member's medical record no later than 15 calendar days from the date of that review. Next slide, please. So in just finalizing the plan that is required, the goals may be rendered in a provider's office and or community or both. Also, it can be rendered individually or in a group setting. Billing shall occur only for the services provided with the individual present, and progress notes should be utilized to summarize the purpose and the content related to the recovery, resiliency, and wellness plan. Next slide. And I'm handing back over to Adam.
All right. And so part of bringing on additional services to help enhance and improve your program is looking at research and looking at other evidence-based practices that have done just that. And contingency management is one of those tools and tasks. There's a wealth of information talking about contingency management being utilized in alcohol-related treatment, cocaine treatment, opiate treatment. And again, the research and the benefits are continuing to be positive, continue to outline why this is an imperative service to improve and to build upon. When I was at the Daily Planet, this was something that was new. It took a lot of buy-in. It took a lot of kind of laying the groundwork of what this may look like. How, if you start this, how is this going to be sustainable? Instead of building folks up and then not being able to continue this program is a huge part of that. There is a bunch of research that talks about how the impact can be more effective than just standard treatment when you're looking at, retention, when you're looking at participation, when you're looking at lowering the time periods that folks, if they do return to use, when there is an adjacent service like contingency management. And again, this program can be highly adaptive to fit a variety of modalities and systems to encourage folks. Next slide. And so a lot of times when you look at contingency management, the hurdles are funding. And what we saw at the Daily Planet with a small amount of money is that a prize, regardless of the amount, had weight and had magnitude. If you have higher funding, if you have donors, or if you have a grant to work off of, again, the higher the incentive, the higher the chance of increasing abstinence. Again, working on the Daily Planet, I was able to utilize a grant for about $2,000, and I was able to provide prizes anywhere from $5 to $10. And those prizes were, people were excited to see them, and they were jazzed to be able to be encouraged. It was mentioned earlier in the slide that positive reinforcement is not something that comes naturally. It's not something that folks hear a lot when they're in early recovery or when they're in recovery period. And so being able to have a system in place, policies in place that reward positive behavior and continue to build on that positive behavior is invaluable. And so there is research that demonstrates that there is long-term behavioral health change looking at low threshold. And so when we facilitated this program at Daily Planet, anyone that came to group was considered a success, regardless if they got high or if they didn't get high the day before or that day. But there was a criteria outlined that, who's on their medicine, who tested positive, and are they working towards their goals? And working towards those goals allowed an opportunity for an incentive. And so incentives have changed. You can, there's fish bowls, there's values, there's numbers, there's a variety of different systems people have used to create their own contingency management. But the biggest key is, instant reward. And so not doing it at the end of the month or quarterly, at the end of the group, allowing that space for the individual to feel celebrated is a big part of this. Next slide. And so when we're looking at this, there's a bunch of research that talks about, you're incentivizing for utilizing other services, access to psychiatry, getting your physical, applying for school, getting your first apartment. And so you're rewarding along those milestones within your program structure has lasting value. The retention rate has been seen to improve when you incorporate programs like this. There's the possibility of creating a fostering an environment that is supportive and encouraging, where folks want to see each other, strive for the best that they can do by building that cohesive group community. Next slide. Again, we're talking about recovery capital, providing skills and services for folks to expand their life outside of treatment can be a big part of the contingency management. I've seen folks receive gifts, and they're going to use these gifts to spend time with their family, with their daughter, or build and develop richer relationships with others. Just as an offshoot of this is a huge component of why we would do this. And again, just ending with a quote that we had a client during Christmas time. He said, "This is the only Christmas gift I received, and I earned it." And every week he came back afterwards, he talked about that and what it felt like to him, and just the pride that he experienced by meeting that milestone was invaluable. So, next slide. So I think that's back to you, Paul.
Actually, I'm going to invite Jason Lowe, the Support Act Grant Manager, to talk a little bit about this, and then we're going to close it out and allow for some questions. Jason, are you with us?
Hey, Paul, thanks. Can you hear me?
Oh, I can hear you loud and clear, man.
Fantastic.
See you too.
Hi, everyone. My name is Jason Lowe. I'm the manager for the Support Act grant, part of the team that Paul and Adam are members of. I just wanted to say real quick thank you to everyone today for participating. The questions that we've got in the chat have been really helpful. And I've asked to join in for just a minute to talk a little bit about something that we want to do as part of the Support Act. For those of you who aren't aware, Support Act is a grant that CMS offered to DMAS as well as 14 other states. It's a planning grant looking at expanding capacity and treatment of substance use disorders through Medicaid. One of the things that we are interested in doing as part of the grant work is to convene a work group looking at OBOT implementation and issues related to implementation of OBOTs in practice settings. And what we're really interested in doing is hearing more from a broad range of professionals about the challenges that exist, as well as the successes that individuals have enjoyed implementing OBOT. We are in the planning phase of this grant right now. And so part of the work that we're doing is really trying to understand the problems and the successes so that we can try and plan for ways to promote and scale up the successes, while also finding different policy and regulatory levers that we might have in place to be able to address some of these challenges. We're going to discuss a wide range of items, and we are going to have data experts join us to be part of this, to have data inform the conversation. A couple of the things that we're interested in talking about are challenges around getting waiver, why some clinicians obtain their waiver but then don't prescribe buprenorphine. Again, we want to learn from successes and identify problems that the Support Act grant team might be able to help address. Next slide, please. So just wanted to put this out there. We're not looking to start this until November. We're anticipating approximately 3 to 4 sessions, 90 minutes each. Again, this is really a problem identification process. It's not a problem solving process. And so we're really interested in engaging conversation and dialogue about the issues, which is why I appreciate some of the issues that were raised in the chat box. These are exactly the kind of things that we're interested in learning about more. And the best way we can do that is to have conversations and dialogue with frontline staff to help and appreciate these challenges. If you're interested or you'd like some more information, please email the address that's there on your screen, and I will put that in the chat as well, supportgrant@dmas.virginia.gov. And it looks like Christine might have already dropped that in there. Thanks, everybody, again. We're really excited to see so many folks taking part today. Look forward to hearing from you if you're interested in the OBOT work group in the future. And I'll turn it back over to Paul. Paul, thanks, sir.
Thank you, Jason. I'm just going to point out a couple of things to folks. If you have questions that we haven't answered, I am going to kind of go back in the last few minutes we have and look at some of the stuff in the chat. But this is our contact information, Adam, Kishan, and myself. Also wanted to point out to you, from April to September, we did what I call Support Act 101. And these are basically 20, actually more like 19 classes that were on basically providing a foundation of knowledge for substance use disorder, as well as substance use disorder treatment. And so these are available to you. The PowerPoints are available you can see it right there. Gosh, because Christine's on the money, as always. You can see it right there. You can download the PowerPoints. If you have questions, I'm happy to answer them, and you can always email me if you have any questions on those. I'm going to have Christine just do our last closing slide, then I'll go back and take on some of the questions. Christine, you got us?
Hi, thank you. Yes, just similar to the pre-webinar survey I emailed to participants, we're also conducting a post-webinar survey. These surveys are done in conjunction with the Virginia Commonwealth University Wright Center and the Virginia Institute for Drug and Alcohol Studies. The purpose of the survey is to identify potential barriers to treating individuals with substance use disorder. Your name and contact information will not be linked to your survey responses. This survey is completely voluntary, and you are also able to complete one survey per each webinar topic you attended. So if you've done this before, you can do it for this webinar as well. Your completion puts you into a drawing to win a $50 Amazon gift card. If you have any questions or problems about the survey, please contact Dr. Lori Kaiser Marcus. Her contact information is also in the chat box. Thanks.
Thanks so much, Christine. We got a couple of questions here on the chat, so I'm just going to that we haven't already dealt with. First was a question: did we have any issues with managed care organization authorizations during, assessments that lasted more than one time? No, we didn't. And part of that was, I believe what I did is, one of the first contact was billed as an assessment. Any follow-ons might have been billed as either case management under care coordination or some other than that. I never had an issue, but if I ever did have an issue with an MCO, I was always quick to let DMAS know, particularly somebody on the arts team, because I wanted to have nothing in the way of providing for our clients. And so again, if you're running into problems with MCOs, there could be a communication barrier there. We let us know, and so that we can address those and smooth anything like that. Let me look here. Barrier crimes, we talked about that. Go ahead.
I have a question in the chat. I don't know if this was sent directly to me or not, but okay. I want to address this really quick. I'm trying to find the question. I'm going to try to summarize it really quick. So basically, the question is, can you clarify how to enroll as an OBOT and MAT? Also, is there still a requirement for the Red Cap survey? And where can the Ipoc be found? So first, I do want to apologize to you because some of the links in the manual may be broken. We are in the process of trying to update our manuals, which is going to take a little more time, but we are in that process. So you can actually, we have an arts webpage. If you email sud@dmas.virginia.gov, I'll put in the chat box, we can send you the link to the arts webpage if you're unfamiliar. You can go to the DMAS website, click on services and click arts, and then click on the different programs and click on OBOT. And when you click there, you'll find all the forms that you need to submit, the instructions to submit on how you do your application to become an OBOT. The Red Cap is still a requirement, and we do ask that be completed. And again, for anyone who has questions specific to art services, anything about the OBOTs, the programs, application process, please email the SUD mailbox. You can't email me directly, but I'll be honest, I will probably just forward them to the SUD mailbox because it's just, you'll get a quicker response there from our team. I just quickly want to say the arts team includes myself, Claudia, who is the policy analyst, and Jessica Johnson, who is our arts service coordinator. They monitor our SUD box Monday through Friday. They answer questions very quickly. We do ask providers to give us 3 business days, but we're usually answering them within a couple of hours. So that is your quickest place for answers to things. Now, I'll give it back to Paul.
Okay, Sean, thanks. There was one other question in the chat. I'm actually going to get Adam to kind of deal with this directly offline if we can. It's about a specific individual who's trained and wants to be a specific peer supervisor training. So I'm going to have Adam address that if we can. In the interest of time, it is 3 o'clock. I know we had a little bit of a snafu at the beginning. I apologize for that. We are going to repeat this training on Monday, October 5th. That will be from 9 to 11 a.m., I believe. In the meantime, just want to thank you for being here. Thank you for all that you do. If you have questions, please feel free to contact us, and we want to help you out as best we can. Until then, take care and have a good day. Bye.